Welcome everyone to this Sunday morning's webinar. This is part of the same series on holistic neurorehabilitation. Today, we're going to be speaking to you about the integration of speech and language pathology along with neuropsychological interventions. I will be starting and introducing the topic of neurorehabilitation, and then Merzia Maskati Shevakramani is going to be continuing. She's a speech and language pathologist. So let's jump right in. Hopefully you all have attended the past webinars where we introduced the topic, and if not, it's also available on our YouTube channel, and that's Synapsium YouTube. All right, so let's begin. I want you all to sort of do a thought exercise and think about what is the definition of communication and how it might be different from language. What is it the same? Is communication always through language, or can it be different from one another? Maybe they're overlapping sort of Venn diagrams. How actually would you define communication and language? So communication, when we think about it, can be verbal as well as non-verbal. Psychologists actually study this, and one of the sort of studies of non-verbal communication is neuro-linguistic programming as well. in all kinds of different psychological pathologies, we actually are taught to look for the non-verbals along with the verbals, especially when we conduct the mental status exam. There is definitely an overlap with language. We do use speech and language to communicate. However, it's not limited to speech and language. There is a lot of communication which can be visual in nature as well. When we're talking about people on the autistic spectrum, there are characteristics of non-verbal communication which take precedence. Social cognition and social communication is something which can be impaired without speech and language being impaired also. Within language, of course, Merzia is going to be speaking to you a lot more about this, but from the cognitive lens, what is important to think about is how through our developmental years, we acquire language. How does the brain actually create language loops? At a later point, how do we comprehend language, which is the reception and the receptive subdomain of language? And how do we produce language, which is the expression? It can be written, it can be spoken. So these would be the three domains of how language is studied. Now, cognition and communication has an overlap. As a practitioner within the field of neuropsychology, cognition is one of the main things that I deal with, one of the main functions of the brain. Now, what is the overlap? What is the link between the two? Of course, communication is an extremely complex process if you think about it. The frontal lobes are involved, the executive functions, so from planning and organizing and decision making, as well as problem solving. Communication involves all of these functions. The temporal and the parietal lobes are also involved in terms of semantic memory. So what is semantic memory? Semantic memory is our knowledge, and it's our memory of certain facts related to language. So language descriptions. When we say semantics, we're talking about the descriptions and meanings of words. So for example, if I was to tell you that it's an animal, it's white, it's sort of furry, it stands on its four legs, it's usually found in very cold places. We use the fur to create clothes for ourselves. The term sheep is your semantic knowledge. So it's also classification, and classification into concepts. And that is an example of semantics. So apart from that, communication also involves thinking and social skills. So from the emotional behavioral personality domain, cognition also involves something, communication also involves something known as social cognition. All right. So what could the resulting deficits because of a brain injury be? Sorry, there is a slide missing. I apologize. So stay with me. I am going to actually describe to you. Now, we're here today to talk about the consequences, the problems that are a result of acquired brain injuries. Now, acquired brain injuries are things that happen to you after the day that you're born. Anything that happens from day one of your life until the end of your life is an acquired brain injury, as opposed to a developmental brain injury, which is something that you could that you're born with. So whether that's cerebral palsy or it is an autistic spectrum disorder, those are developmental neuro disorders. So within the acquired brain injury domain, it could be any kind of an injury ranging from degenerative disorders like dementia, Alzheimer's, Parkinson's, or it can be contact related injuries, which could be direct trauma to the brain or the skull. It can also be related to metabolic disorders, tumors, also because of psychiatric. So chronic psychiatric illnesses also lead to brain injuries. If we were to think about continued chronic alcohol abuse and dependence, it leads to a cognitive disorder. It can lead to a cognitive disorder known as Korsakoff's syndrome, which is very, very extreme memory loss and confabulation. So creation of non-existent memories. So just to give you the background, these are the acquired brain injuries that can occur. Now, we're not here to actually talk about the different types of injuries, but the commonality of consequences of these injuries. So some of the resulting deficits could be attention and concentration difficulties, reduced insight into one's characteristics and capabilities, impaired social communication, literal interpretation, which means that our ability to pick up sarcasm or our ability to actually read in between the lines, our ability to understand proverbs, metaphors, these would be hampered. Now, if you can think about it, these are very, very sort of higher order cognitive functions. We're not talking about the base level of functions, but they can very often, go unnoticed or not linked by the lay community or people who are not educated in neurological deficits. They might not be linked, or people might not be able to make the association with brain injuries. And this is actually where it's very important that as a psychologist or as a healthcare practitioner, even if we're from the paramedical field or tertiary care providers, it's very important for us to be at least somewhat educated and aware, so that when we're taking a clinical history, we do check for a history of brain injury. Now, whether we ask if they've had any falls and brain injuries, were they hospitalized because of it, or have they had a history of epilepsy? If we're working with elderly patients, definitely very important to ask about any kind of cognitive changes, or if they've had a stroke. Just checking for the history is going to lead us in the right direction of probing. Now, apart from that, memory problems, of course, this is something that we're very aware of also, and so is the community. Um, Most families, when they walk in, they will sort of diagnose and have the misconception of any kind of a cognitive issue being labeled as a memory problem. Impaired reasoning and problem solving is another one. Now, cognitive fatigue and frustration, this is very important, because again, these are subtle things. Now, when we are to sort of put it in the link that we're trying to find between cognition and communication, because of certain types of cognitive communication difficulties, which Marcia is going to speak about in detail, I want you to think about what could be the emotional ramifications of those kinds of deficits. And hint, hint, fatigue and frustration are things that I want you to definitely think about. Of course, depression is something that will become very obvious. So while Marcia is describing them, please think about the emotional consequences of the same. All right. So now, what is holistic neuro rehab? Holistic neuro rehab keeps the patient at the center of everything that is planned and created within the treatment program. The individual is viewed as a whole. So, what makes you you? I want you to think about that. So, how would you describe yourself? You might say that, okay, I am a girl, I'm a boy. So, we might identify with our gender, we might identify with a culture. You might say that I'm Gujarati or I'm Muslim. It depends on how a religious background is also part of our identity. You might say that I'm a psychologist or I'm a speech therapist, your profession. There are lots and lots of different things that we would call um, uh, describe ourselves within the domains or within the sort of paradigm of. Now, if we were to take it deeper, what makes you you? I would get into my educational qualifications. I would get into my physical characteristics. Now, I very clearly know that I cannot be a marathon runner. So that's my physical capability. Um, as you continue to describe yourself, or as you try to describe who you are, all of these different domains that are listed before you start to become apparent. So the psychosocial, cultural is one domain, emotion, behavior is another. Yes, sometimes I can be sensitive. That sort of can go into it. The idea of putting yourself within this framework is something that I want you to do as an exercise. Um, Now, the role of a neuropsychologist looks at three of these various domains that I have listed: cognition, emotion, and behavioral psychosocial. So, everything that involves our thinking processes. So, memory, attention, reasoning, problem solving, all of that comes in. Language also falls within this, and our role as a neuropsychologist is to look at the impact and the interlink of language with other functions. I'll give you an example. If I have very severe distractibility, it's going to impact my ability to communicate or to engage in conversation with people around me. Now, this is a very obvious, simple example, Let's take it a level deeper. If my ability to read, so the ability to actually understand what is written in front of me, my reading abilities are absolutely intact. However, my reasoning abilities and problem solving is severely impaired, working memory is severely impaired, I'm not going to be able to get through a book or sometimes even a newspaper article. And that's not because of purely the language loop within the brain. It's because of the interlink to other cognitive functions. Emotion, as I explained, is something that I want you to think about while Marcia is describing the symptoms, as well as the behavioral and psychosocial. So it is something, if there is continued chronic difficulties with language and communication symptoms, if those symptoms continue to persist, it's going to impact one's interpersonal relationships. It can lead to isolation and withdrawal from relationships, which can further lead to uh, sort of disconnect and apathy, where an individual starts to sort of lose the interest of communicating with people and um, indirectly becomes isolated, leading to a whole host of other emotional difficulties. All right. So, all right. So I am going to describe to you a little bit about the multidisciplinary team. Um, sorry, just one second. All right. So getting back to the role of a neuropsychologist, actually, I will describe the team, the multidisciplinary team, a little later. Um, Now, as part of a neuropsychological evaluation, this is something that we work with. So don't get overwhelmed. I just want you to sort of understand how we link everything together. So, right at the top, we're describing the etiology. So, this is the sort of medical etiology. Now, what had actually happened to the individual? What kind of a brain injury is it? Because brain injury is a huge umbrella classification term. Within that, as I explained, there are lots and lots of different possibilities. To the right of that in green, as you see, is identity. This is us viewing the individual as a whole. What kind of values, passions, coping style. Now, these are very sort of positive positive psychology concepts. To the left, as you can see, is the social network. What kind of support system is possible for us to use within the neuro rehab paradigm? How will we create the best kind of support for this individual? As you can see, there are lots and lots of interlinked arrows trying to show us what impacts what. At the center is affect and emotion. At the bottom, as you can see in the teal color, is functional consequences. Extremely important for us to identify, because the entire rehab treatment plan focuses on goals. It focuses on creating and prioritizing the goals that we're going to work with, creating a time bound approach. So, what is the initial goal? What are the preliminary goals? As you can see, getting the individual independent or in their daily living activities could be one specific one. Apart from apart from these domains that I described, of course, cognitive impairment comes in, physical impairment also comes in. Now, this is an evaluation from a neuropsychologist perspective. So within physical, we will sort of include sensory issues, physiotherapeutic issues, very often even speech and swallowing issues fall within all of this for us. And this is the domain that a neuropsychologist will look at to be able to liaise with other professionals. Now, how does a neuropsychologist actually address these issues? Lots and lots of different strategies. So sometimes they're compensatory behavior modification strategies. And sometimes it's a restorative approach where we're actually trying to restore that cognitive function through rehabilitation. Also, there's definitely a very, very strong influence of psychotherapy, whether it's emotional support for the patient or the family, and overall getting the individual functional. Now, what that means is if there is a severe disorientation of date and time, the individual is not going to be able to plan their day. Um, Even if they have very independent physical capabilities. So, inability to recognize the time of day would mean that they don't know um, that now it's time for lunch or breakfast or exercise. So, getting that in order is one of the initial goals. Apart from all of these, something that I did not address even in that diagram is insight and self-awareness. Now, the symptom when there is lack of insight and impaired self-awareness, it's called anosognosia. So now that would mean that the individual is actually unaware of having had an injury, which if that is the starting point, if they do not know that they have had an injury, and this is not do not remember, but this is do not know that they have had an injury, they're not going to know that they have the consequences related to that. Very often they actually do not know about physical issues, which can lead to them trying to get out of bed and having a secondary injury because of a fall. It can lead to them underestimating the overall problem. It can lead to absolute sort of non-cooperation and not participating with the rehabilitation professionals. Also, reduced motivation. Why should I participate? I'm absolutely fine. I mean, I am a well qualified psychologist. I have very good degrees. Why are you trying to make me, you know, use a calendar uh, to remember the date and the time? I mean, this is so demeaning. These are the kinds of thoughts that can come up. Unrealistic expectations about the outcomes. This is, of course, later in the treatment process of a severe brain injury, and inaccurate self perception. So, by definition, this is looking at the function of the brain known as metacognition. Now, holistic neurorehabilitation, it involves multidisciplinary teams. And these teams consist of professionals who work in parallel, but they have their own clear, defined roles and tasks. But interdisciplinary teams, so there's a slight difference between multidisciplinary and interdisciplinary. Interdisciplinary teams collaboratively discuss and set treatment goals and then jointly carry out these treatment plans. Of course, we try to work within both of these paradigms and we create the best possible system for the client that we're working with. So there have been times that Merzia and I have had meetings to discuss clients and to discuss goals and to discuss plans of what we're actually going to do in the sessions, how we're going to further define our roles. Now, the benefits of working in this multidisciplinary setting is that patients have actually been able to identify how they're going to, how the rehab is going to be most efficient. Rehabilitation roles and activities, of course, will often overlap. Goal setting, education, assessment also can overlap. However, there's always things that we will add to each other. And those are the benefits that are viewed as the maximum benefit for the client and the family involved. There's enough research actually out there to show that the positive impact on these client outcomes is exponentially greater when we're working within this multidisciplinary domain. Now, cognitive rehabilitation actually has also been identified as this area of overlap between actually three professionals: neuropsychologists, speech therapists, as well as occupational therapists. However, this is not looked at as a concern. This is always looked at as a benefit. So when we're looking at holistic neuro rehab, once again, these are the domains that we're going to address. And the different professionals are going to come together to actually address all of these for the clients. Apart from this, some points which are important for us to actually understand are the fact that standard rehabilitation usually involves very individualistic sort of discipline specific therapies. However, this holistic intervention, the thing that is additional is that the team regularly meets to reassess the patient's state and progress. They continuously meet at regular intervals to actually redefine the goals as well. Also, frequent education of the patient becomes a given as part of these meetings, which helps include them in the process because it creates and it fosters this comprehension of the treatment plan, the outcomes, and the difficulties that the patient is actually going through. All right, so so this was the slide. These would be the different professionals involved to address the difficulties listed over here. So the doctors, of course, are involved in the initial part of the patient's treatment, stabilizing the patient after a brain injury, or of course, if a surgery is required. However, once the rehabilitation process begins, and just to give you a timeline, the medical part of the sort of medical period of care is usually very limited as compared to the rehabilitation timelines for severe brain injuries, actually moderate to severe brain injuries. The rehabilitation period can go on for months to years. All right, so now to bring Merzia to speak to you. Merzia is a speech and language pathologist, and she has a very successful private practice, and she has been working in this area for several years. And without actually spending more time on her introduction, I'm going to invite her to actually come in and speak to you. So Merzia, I have now made you the co-host. So please go ahead and share your screen.
Hi everyone, thanks Shraddha. Okay, I'm going to share my screen. Okay, so I'm going to be talking about speech. So SLP is speech language pathologist. So speech language pathologist and acquired brain injury. So I'm going to talk about how acquired brain injury affects speech and language, and then the role of the SLP in brain injury management. Okay, so acquired brain injury is basically divided into two types. I'm not talking about developmental brain injuries at all in this presentation. So it can be traumatic, which is through falls, motor vehicle accidents, gunshot wounds, blast injuries, and non-traumatic, which is through strokes or any sort of metabolic disorders, tumors. And both of these are seen in kids as well as in adults. Okay. So depending on which part of the brain is affected during the injury, we see different sort of characteristics. So according to the different lobes of the brain, you see different characteristics. Most of the speech and language areas are in the left hemisphere. Um, so when you have a left hemisphere injury, sorry, I can hear an echo. Yeah. When you have a left hemisphere injury, you see the speech and language affected a lot. But then there is also a right, when the right hemisphere is impacted, there are also speech and language impacts, but they're more subtle. Okay. So like the different lobes of the brain we have, like the frontal lobe, if the injury were to impact the frontal lobe, it may cause difficulty recalling events or speaking. And if it affects the parietal lobe, you see, problems with communication and memory. But usually, a brain injury isn't so neat. It doesn't really impact just one area. So the areas of the brain that impact language are highlighted. And again, different speech disorders are called according to the area that's impacted, but it's never that this neat. So I wanted to highlight traumatic brain injury. Okay, it leads to cognitive problems like Shraddha talked about, executive functioning problems, sensory problems, and behavioral and emotional problems. From a speech therapist perspective, the one big area that traumatic brain injury impacts is communication, and especially social communication. So non-traumatic brain injuries also impact communication, but the social communication challenges after a traumatic brain injury are pretty, apparent. And sometimes they're very obvious, sometimes they're more subtle. But these challenges are like difficulty organizing thoughts or ideas, and basically difficulty following the rules of a conversation. So like when to take a turn, how to talk about something that's relevant, how to stop talking, how to start talking, and how to, understand nonverbal signals. So these are some things that speech therapists work on when people have a TBI. Broadly, the speech and language disorders that you see after an acquired brain injury, including a traumatic brain injury, are 4 of them. Different kinds of aphasia, dysarthria, apraxia, and dysphagia. Okay. The one that we most commonly see is aphasia, and then dysarthria and apraxia can co-occur with it. Okay. So aphasia most commonly occurs from a left hemisphere injury. Okay. And it results in impairment in 4 primary areas, which are spoken language expression, spoken language comprehension, written expression, and reading comprehension. Okay. So you can broadly classify aphasia as a fluent type or a non-fluent type. Okay. And 10% of people who have strokes also have apraxia with it, and 40% also have dysarthria with it. Okay. So the symptoms of aphasia, when we say, again, they're divided into the 4 domains. So when there are spoken language issues, it can be, okay, someone may speak completely fluently post any sort of acquired brain injury, but they may have trouble finding specific words. So that's what we call anomia. So they may be talking and then say, oh no, what was that place? I can't remember the name. I can't remember the name. So that's what we call anomia. They may speak haltingly or with effort, so it may look like very effortful speech. Okay, it may be telegraphic speech, where they're just using small utterances. They may make a lot of grammatical errors, put words in the wrong order, substitute words, and sometimes they also make up words. Okay. When it comes to spoken language comprehension, okay, after an acquired brain injury, someone may take an extra time to process spoken language. And this, I think, is something that we see very, very commonly, that it just takes extra time to process. And it's important to give the person that amount of time to follow the spoken message. There may be unreliable answers to yes and no, and it may be very difficult to follow fast speech, like on a radio or a TV. So very often, people tell us that, oh, this person used to watch all these serials before. Now they don't feel like doing anything. They don't feel like watching anything. But that's because it's kind of hard to follow that speech that's so fast. And, again, where the social bit comes in, they may have difficulty understanding the subtleties of language. They may take the more literal meaning of things. In terms of written expression, okay, again, someone who has an acquired brain injury and who may have been, highly successful in their field earlier may now have trouble writing or even copying simple words and letters, or they may again have run-on sentences and that don't really make sense, and the grammar can be impacted. And in terms of reading, they may have difficulty comprehending written material. They may have difficulty recognizing some words by sight. And again, they may make word associations and substitute words. So the role of the speech therapist in treating aphasia is to provide prevention information to at-risk groups, okay, educate other professionals, and then diagnose, screen individuals who have acquired brain injuries and develop treatment plans. Okay, and then obviously carry out the treatment, and like Shraddha mentioned, serve as a member of the team that includes other professionals. Okay, so the treatment of aphasia, again, like Shraddha mentioned, can be restorative, which is improving or restoring the impaired function, or compensatory, which is aimed at compensating for deficit, okay, that you can't retrain. When it comes to like treating aphasia, it's very important to understand that like sometimes you're actually teaching the person the language again, and it's difficult. It's like, I mean, I compare it to I'm learning all this technology stuff now, stuff that I never used to use before, and it's like retraining and relearning for my brain. So it's pretty hard. And it gets pretty frustrating for someone who could do it very easily before. So there are different types of treatment approaches, and one type is what we call AAC, which is alternative and augmentative communication systems. Okay, so these initially, when someone has an acquired brain injury, sometimes they may have no speech, or they may have very little speech. So we use some sort of AAC system, which can be aided, which is using an external device, like an electronic device, or it could be using picture communication, just to get them to start communicating their basic needs. You also have unaided AAC systems, which is using things like gestures or finger spelling to get their message across in the absence of using verbal speech. And then there are other kinds of treatment approaches, like PACE and visual action therapy, and MIT, which is melodic intonation therapy, is used for people with very severe aphasia, where you use a kind of rhythm and a tone to pick up language. So you're kind of using the right hemisphere functioning to pick up for the left hemisphere. Okay, and the recovery of language depends on the type of aphasia and how the languages were acquired. So for someone who's bilingual, and how proficient they were in each language. And it's very surprising. Sometimes, they pick up a less used language better. Then the second condition that speech therapists work with is dysarthria. And this is caused by weak muscles due to an acquired brain injury. And it's a motor speech disorder, and it can be mild or severe. So the symptoms of this are, slurred or mumbled speech that's hard to understand. And again, this can co-occur with aphasia. So it's not always just one thing. The person may speak too slowly, speak too fast. They may not be able to speak loudly enough. They may not have enough breath control to talk. So the role of the SLP in treating dysarthria depends on the type and the severity of the dysarthria. So it can include things like slowing down to speak, using more breath support to speak, more articulation therapy to move the articulators better. And again, if it's very severe, then using other ways to communicate, like gestures or writing, or using electronic devices. Apraxia, which is the third thing that speech therapists work on, is a neurological speech disorder. And in this, the sensory motor commands necessary for moving your articulators are affected. Okay, so it's also called verbal apraxia or dyspraxia, and it occurs with dysarthria and aphasia. Okay, but the thing with apraxia is it doesn't involve any sort of muscle weakness or paralysis or spasticity. Spasticity. Okay, um, so sometimes very initially after an acquired brain injury, you see apraxia, and then it can improve over time. Sometimes it's only seen in the acute stages, and then it kind of recovers. Sometimes it remains stable, and sometimes it actually worsens. Okay, so the key symptoms of apraxia are that there's a reduced overall speech rate, and the phonemes that you pick up can be distorted. Okay, you can make additions to them or substitute them, and there's the syllable segregation, is impacted. So the intonation of the speech is impacted, and the longer the utterances go, the harder it becomes for these people to kind of imitate that or say that. So there are different methods to to treat apraxia, which is again like multiple input phoneme therapy. These are just some names of treatment approaches. Tactile cueing. A very popular one is prompt, which is prompt for restructuring oral muscular phonetic targets. So it's where you're actually retraining the muscles. And then the last disorder that speech therapists work on is dysphagia. And there are different types, but the one that's most commonly associated with acquired brain injury is oropharyngeal dysphagia. And in oropharyngeal dysphagia, some symptoms are, your throat muscles may be weaker. The timing of the swallow can be impacted by the acquired brain injury. So it makes it difficult to move the food and liquid, from your mouth back to the back of your throat. So you may cough or choke or gag when you're trying to swallow. This may happen with certain consistencies of food and not happen with certain consistencies of food. You may have pain while swallowing. You may have frequent heartburn. And the reason why we work on this and what we want to avoid is any sort of pneumonia. Because if food goes down the wrong way and it goes into the lungs, then it leads to an aspiration pneumonia. Okay, so the speech therapist in treating dysphagia, we do swallowing therapy. We give swallowing exercises to strengthen the muscles. We recommend diet changes of how to change the food so it doesn't, cause any difficulty. Positioning changes, how the person can be seated, how they should be looking so that they can swallow better. And if it's very severe, in recommendation with the doctors and stuff, we recommend tube feeding, which is either an NG, which is nasogastric through the nose, or a stomach tube, which is a PEG. And yeah, if anyone has any questions.
Yes, if there are any questions, you can post them in the group chat. As you can see, I'm actually just replying to Shashi's messages. All right, so Shashi has sent one more question for you.
Yeah, I can answer that. Is stuttering a language pathology, and how can this be treated? So stuttering is a speech and language issue, but it doesn't come from a brain injury. There is a sort of stuttering that does come from a brain injury, and that is called neurogenic stuttering. So that's very different from the stuttering that you see when kids begin stuttering. So neurogenic stuttering occurs after any sort of, acquired brain injury. And it sounds exactly like the stuttering that someone has developmentally. The only difference is that it comes after the brain injury, and developmental stuttering starts in early childhood around 3.5 to 4 years of age.
All right. Do you want to take the next one about anomia? How is semantic dementia managed?
So with semantic dementia or anomia, we work on a lot of word finding, strategies. So we do a lot of, retraining. to get the person to either, again, use things that can help them in their everyday life when they're having word finding issues. And then we eventually do things like, activities like naming synonyms, opposites, convergent naming, divergent naming, categorization, all those things to help, get word recall.
Right. And also, yeah, so I think identifying what other cognitive functions can actually support and help compensate for the anomia, and actually work with those, that's also something which would be done. So compensatory strategies, I think, a lot more. Yes.
Yeah. Yeah. All the speaking.
Right.
Sorry.
Yeah.
This
no, go ahead.
actually, no, this is actually a big one. So with communication deficits, there is a huge amount of depression, and, and that's when it's really important to work as a team, because that's not a speech and language therapist, domain. But it needs to be dealt with, because unless the depression is dealt with, it's not easy to bring about changes in the communication, because it's a huge shift to get used to, again, if you were a certain way and, you had a certain life, and then suddenly get used to not being able to communicate that well and not being able to go back to what you used to be. It's a shift that you need to, professionally deal with, and as well as work on your communication.
Right. Absolutely. I think creating the kind of hope and adjustment is very important to actually for the outcomes, to improve the outcomes of rehab. And the stuttering, you spoke about being treated.
Yes, it can be treated. Again, there are certain techniques that we use to work on pacing the person so that they get enough time to. Basically, it happens between an in-coordination between breathing and speaking. So, we do certain pacing techniques so they can pace themselves to give themselves time to coordinate their breathing and speaking to reduce the disfluency.
All right. Can both psychotherapy and speech and language therapy, can the individual undergo both at the same time? Yes, absolutely. The interdisciplinary and the multidisciplinary setting usually involves all of the therapists working at the same time. So the goals for each therapist could be very different. So the neuropsychologist or the clinical psychologist as part of the team could have goals related to emotional support, while the speech pathologist could be working on, for example, anomia.
Yeah. And I mean, also during a therapy session, it's always the emotional part comes out, I think, with every therapist. And, every therapist kind of talks to the person about it, but it's nice if they speak to a professional on the team, to get some guidance with the emotional bit.
Absolutely. I think emotional support and the foundation of self-awareness, these are the two things which are going to help in the overall outcome for all of the different therapists. I think these are the two things that definitely will impact the rest of the outcomes also. So, right. I think there's one more actually. What difficulties are faced with rehabilitating them?
Yeah. So actually, I don't really work that much with people who are hearing impaired. But I mean, from long time ago, I can tell you that, those who use sign language, if they are using the sign language, so there is a very big deaf community, especially in the US. And this thing, so they kind of use sign language and have their own community, and they're very safe and secure in it, and they don't feel the need to learn any sort of verbal speech. So it's just a different way of looking at it.
Absolutely. If a bilingual person keeps mixing,
if a bilingual person keeps mixing, I can't see that. Sorry.
oh, you can't see it. Keeps
No.
mixing the two languages while speaking. Is it some kind of a sign of the degeneration of brain areas?
No, that wouldn't be a sign. Again, it just depends on which language was, which language they picked up first, which one they were more proficient in. And sometimes after a brain, I mean, there's a lot of research on bilingual people and brain injury and how languages kind of come back. But it does happen that people end up mixing a lot of them. So, and that's okay. It doesn't indicate anything.
It is said that some cases may worsen with time. How to deal with that? So I think, Mandira, you're not specifically asking about any symptom, right? I think overall you're asking about the prognosis and the outcomes. So this is, I think this becomes very, very important, how to actually break the news to the family, how to actually let them know that despite all of the long-term rehab, some deficits are going to be permanent. Now, this is something I think that all of us do very carefully as rehab therapists, because we will know based on the initial etiology that some damage is going to be permanent if the injury has been severe or profound. So whether we're able to guide the family about the specific symptoms that are going to be permanent, that we might not do, but we will definitely get them sort of ready to accept that a lot of the damage could remain permanent. Now, apart from that, when you ask about the worsening over time, I think you're talking about the secondary degeneration related to the initial brain injury. And once again, I think that's one of the extremely sort of difficult and disheartening things for families to deal with, because despite the effort, despite the sort of hard work and support that they provide to their family members, if this is happening, psychotherapy is one of the ways to get them to deal with that. So we might use acceptance therapy, we might use mindfulness based interventions, and definitely sometimes also different forms of logotherapy. I'm not sure if that's what you were going for, but let me know if that answers your question. Morzia, you want to add anything actually to that?
No, that's good.
Yeah.
That's good. This one I was going to answer. This, does aphasia take place in non-traumatic brain injuries too? Yes, absolutely. The only reason I was highlighting traumatic brain injuries separately was because traumatic brain injuries, post that, there is a huge social communication deficit, which you don't always see with non-traumatic brain injury, but aphasia takes place in both.
I have a question here for you, I think, which was sent privately. What if a person does not have any ABI, but yet talks very fast? What is the reason for that?
If a person okay, so there are a lot of people who talk very fast. Sometimes it's just natural. It's the way they talk. It's not something we treat. If it's fast enough to the point of them, mumbling and, repeating themselves a lot and not being understood, yes, that is something we work on. That comes under the domain of fluency disorders. Okay, so sometimes stuttering is one type of fluency disorder, and this going excessively fast and repeating yourself is called cluttering. And there is a neurological basis to it, but again, it doesn't come from a brain injury, but there is a neurological basis to it.
Can you share a case regarding today's topic before ending this webinar? Sure. So a case presentation impromptu. Maybe we can talk about RA.
Yeah, sure.
So I think her speech and language difficulties actually preceded
were the
a lot of
yeah. So this was a teenage girl, and she had a traumatic brain injury, and following which she had absolutely no speech and language for the initial few months, I'd say 5 to 6 months. She had no verbal speech and language. So we used an assistive technology app to get her to start communicating. And initially we had to do it with just a picture board. So she just pressed a picture of what she wanted or who she wanted to call in her family. And it was a voice output. It would say it out loud, the app. And then she had enough motor control to do that, to operate an iPad. And then we went on to making it written and not picture based, and she could do that. And then she began typing. So as her her injury kept resolving itself, and as she started picking up more and more function, she was able to type fully on this iPad. So she typed her entire message out and then press it, and then I would have a voice output and she'd be saying it. And then she began speaking slowly and slowly. So again, from a speech therapist perspective, we faded out the assistive tech and started working on her speech clarity. So it was both, there was an aphasia and there was dysphagia. So we were working with both elements. And that's as far as her speech and language thing went. And now, many years later, she's talking fully. But she's still a little dysarthric.
And so the same girl, actually, while she was having the speech and language difficulties, of course, the initial assessment had to be conducted while she had no speech. So when I had to conduct the initial neuropsych assessment, it was very difficult because all of the instructions actually had to be given to her very, very slowly. Getting to know someone who has had speech and now has suddenly lost it leads to a lot of psychological issues as well. And so there's things like fear, shock, of course, lots of frustration. So it kept coming in the way of the initial assessment that I needed to conduct to actually be able to create a plan for her cognitive rehabilitation. So being able to identify her strengths and her weaknesses within the cognitive domain, that was very challenging. This was at the very beginning. And then, as Morzia said, as her ability to communicate actually got better, there were tasks that were created around that within the neurocognitive and the neurobehavioral domain. So once her ability to actually write, so more narrative writing, there were assignments and there were tasks given to her to actually be able to process what had happened to her. She had a very long-term post-traumatic amnesia and continued lack of self-awareness for a long period of time. So the writing assignments were focused on that. And then once that ability got better to actually write, repetitive writing during sessions and then after helped her build better self-awareness also. So I think this would be one of the ways that we collaborated and worked with each other. All right. So thank you, everybody, for attending. And hopefully see you next Sunday. We're going to be talking about family-based interventions as part of neurorehabilitation. Thank you, Morzia, for joining us.
Thank you.
Very, very helpful.
Thank you.
All right. Enjoy your Sunday, everyone. Bye. Bye.